Okay, let's take a 62-year-old man with a PSA level of 41.32 in December of 2017, and then a PSA that rose to 53.97 nanograms per ml on 2/26/18. The patient has had two negative prior biopsies, one in 2014 and one in 2015. So our purpose in illustrating this case is twofold. One, to illustrate the pitfalls of very far anterior cancers and how they can blend in, even on MRI, with the anterior fibromuscular stroma, and as a subset of that, be very difficult to access biopsying the gland from the back because they're so far anteriorly. The second thing I want to do is once again illustrate T staging. So let's talk about T staging for a moment. You know, a T1 stage is a clinically inapparent cancer. A T2 stage, just for basic, it's confined to the gland. And then you can break that T2 stage up into T2A, T2B, and T2C. An A involves one half of one lobe, a B involves more than one half of one lobe, and a C involves both sides of the gland, so both lobes. A T3. A T3 extends through the prostate capsule. You've got a T3A, which can be unilateral or bilateral capsular extension, and a T3B, which invades the seminal vesicles. And then you've got a T4, where the tumor is fixed or invades adjacent structures other than the seminal vesicle, like the external sphincter, the rectum, the bladder, the levator muscles, the pelvic sidewall, and so on. Then you could also assess the status of regional nodes, as we've discussed in other vignettes, and you can look for distant metastases, so that would give you your end stage and your M stage. Go to those vignettes for assessment of those criteria. So let's take this case. We scroll axially, and there should be a thin, lentiform fibromuscular stroma. How thin should it be? Maybe 6, maximum 8 millimeters. So it might look like this. But it shouldn't really look like this. There's just too much charcoal-like, smearing-like, dark signal intensity anteriorly. Now you might say to yourself, well, okay, how much is too much? Well, I've given you a number, but don't get so fixed on the number. You know, maybe there are some people that have a 9 millimeter anterior fibromuscular stroma. Maybe they have a 3 millimeter. So let's use what's available to us. So let's go to the coronal, which is probably going to be the least useful projection because we're tangent to or parallel to the tumor, but it's awfully smooth and gray, charcoal-like. That's a bit disturbing. Let's go to the sagittal, where it might be more helpful, because we're going to be perpendicular to this potential crossing side-to-side tumor that is blending with the anterior fibromuscular stroma. And there it is. Well, it's not just lentiform side-to-side, it's lentiform up and down. Here it is. It goes all the way from here to here to here. Oh, it's a lot bigger than it looked in the sagittal projection. The sagittal was very helpful. And we have more than 2 centimeters of anterior capsular contact with bulging anteriorly. So you should at least suggest the possibility of micro-invasion of the anterior capsule, which would make this a potential T3 lesion. Now, what else can we use to supplement our suspected diagnosis of a cancer and a RADS 5, meaning it's greater than 1.5 centimeters. In fact, cranial caudata was well over 2 centimeters. And I would use the diffusion image. So let's go to it. I wouldn't use the dynamic contrast enhanced MRI. That's probably my least favored nation sequence. Let's go to the diffusion image, the B1600 image, and right there, in the area we were suspicious, let's blow it up and make it bigger, we have diffusion restriction. There it is. You can scroll it. It's on multiple axial sections because it goes all the way up and down the base and apex of the anterior gland. Let me show you a B value that is 0. You really don't see anything, do you? Let me show you a B value that is 50. You really don't see much. When you go to the higher B values, say 1200, and then to 1600, the cancer is diffusion restricting and separated from the rest of the gland. Let's compare it with the ADC map, in which the signal intensity should be low, and it is. And we can scroll that and see the volume of cancer and potentially trace it on the T2 and the diffusion weighted image. Now let's go back to the morphologic image for a moment, and I'm just going to one-up it, and let's make a survey. Now some of you may like to have a T1 weighted image, or a 3D T1 appearing image, such as a T1 GRE with thin slices, to look for nodes and separate them out from vessels, and look for bony metastases and other morphologic abnormalities, and that's perfectly reasonable. You could also use a high-quality T2 to do that, although it's not as easy. But if you're very experienced, you can use the T2. Let's do that, and what are we looking for? We're looking for solid, round objects that don't have a fatty hilus in them, and they're not tubular. So let's keep scrolling, and I see some flow voids in the femoral artery and vein, and I see a gray, oval, or round structure on both sides. And it's too big, and it's too bulbous, and it's too juicy, and it's got a convex outer border. It's not crinkled. Most nodes that are benign look like this. They kind of have this crinkly look to them. And in the center, they'll have a little bit of fat. No fat, not crinkly, very bulbous, and in this case, bilateral. This is regional lymphadenopathic involvement by prostate cancer. So if we were going to end stage this, we would give this an N1. N0, no nodes. N1, regional nodes. And then if we had distant metastases, we'd go into our M staging. So this case is illustrative of 2, perhaps 3 key teaching points. 1, that anteroapical lesions can blend in with the anterior fibromuscular stroma and easily get missed on imaging. As a subset of that, 2, biopsying the gland from the back may not make it easy for the surgeon to access this very far anterior tumor. And 3, when you're T-staging these lesions, evaluate the capsule on both sides, and do not forget to evaluate the skeleton and the other associated accessory structures in the neighborhood, like the seminal vesicles, like the capsule, like the regional lymph nodes, which were positive in this patient. And for those of you that were dialing in and watching everything, there is a huge cyst in the testicular region, an epididymal cyst, which is gigantic on the film edge. This is an example of a RADS 5 in the anterior fibromuscular stromal region, both at the apex, at the middle of the gland, and the base of the gland, running all the way anterior, up and down, with suspected capsular microinvasion.